So now will be my good friend, Dr. Muhammad Shawal, our consultant cardiologist. Is he around?
Yes, Prof. I'm around.
Yes.
I've been
Okay,
listening to the wonderful lectures.
Okay, so dipersilakan Dr. Shawal.
Sorry, this is the wrong background actually. Let me share my screen. Okay, Bismillahirrahmanirrahim and Assalamualaikum everybody. Before I start, say this, kehadapan yang teramat mulia Datuk Seri Diraja Tan Sri Tengku Intan Syafinas binti Tengku Abdul Halim Muazzam Shah, izinkan Patik mempersembahkan tajuk webinar ini iaitu Scleroderma dan Pulmonary Hypertension, or English Scleroderma and Pulmonary Hypertension. Assalamualaikum and a very good evening everybody. First and foremost, I would like to say many congratulations to Prof. Shahri and his team for the wonderful hard work that they have done to establish this pulmonary, Scleroderma, Persatuan Scleroderma Malaysia. And without further ado, I will start with my topic of my talk today, which is Scleroderma and Pulmonary Hypertension. So this is the pearl of wisdom that I would like to decimate today. And first, we're going to talk a bit about the pathophysiology of scleroderma and its association with pulmonary hypertension. Then we're going to talk about the importance of treating the right type of pulmonary hypertension in patients with scleroderma. And I'm going to emphasize on screening, because screening is very important. When screening for pulmonary hypertension is very important in patients with scleroderma. And how do I treat my patients with pulmonary arterial hypertension specific medications? So let's talk about pulmonary hypertension. So pulmonary hypertension is a myriad of cardiovascular causes, and it involves endothelial dysfunction, smooth muscle hyperplasia, and also inflammation and dysimmunity. And it is governed by a lot of factors. For example, now we know that genetics play a role, which is the BMPR2 mutation in your gene can lead to what we call familial pulmonary arterial hypertension, and other things like Acinetobacter, hypoxia drugs, and also other stimulus like shear stress or some virus infection. We know that I haven't seen yet, but I suspect if we have a COVID-19 screening, and we will hopefully see patient who has pulmonary hypertension secondary to COVID-19, but that's non-reported yet so far. Okay, so and imagine pulmonary hypertension when you have something blocking your heart, right? So the heart pumps blood to the whole body, in particular to the lung. So in the lung where the oxygen happen, and because of there's a blockage in the blood pathway to the lung, so this leads to pulmonary hypertension. And this blockage can occur in many ways. So you can have blockage in the pulmonary arteries by virtue of atherosclerosis. You can have blockage because of clots in the lung, and also you can have problem inside the heart itself. You know, you have congenital heart disease, and whatnot, and which leads to this pulmonary hypertension. So it is important to note that in the 6th World Symposium on Pulmonary Hypertension in 2018, it is decided that the mean pulmonary pressure is more than 20 millimeter mercury. And when you have this mean pulmonary arterial pressure more than 20 millimeter, you are diagnosed to have pulmonary hypertension. And this hemodynamic is obtained from right heart catheterization. And it is important that you don't obtain this value from echocardiogram. So echocardiogram is not a tool for diagnosis; it's a tool for screening. And when you wedge the pressure in the from the right heart catheter, you will obtain this what we call mean pulmonary arterial pressure. And when the this pulmonary capillary wedge pressure (PCWP), and when the pulmonary capillary pressure is low, which is less than 15, and when and from there on we obtain from certain calculation we obtain this pulmonary vascular resistance. And if the pulmonary resistance is more than 3 Woods unit, then this is diagnosed as pulmonary arterial hypertension. Okay, so this is important to note that when we talk about pulmonary hypertension is a big thing, and pulmonary arterial hypertension is part of pulmonary hypertension, and it is further complicated when we try to associate this with scleroderma, because in patient with scleroderma, and we know that pulmonary hypertension affect both localized and systemic scleroderma, but we see pulmonary arterial hypertension more in the localized group of scleroderma. We see pulmonary hypertension by virtue of secondary to lung disease more in the systemic scleroderma. So understanding this natural history of scleroderma is important. So if you have diffuse scleroderma, you might have pulmonary hypertension from secondary pulmonary fibrosis, and if you have this limited scleroderma, your pulmonary hypertension, it would most likely probably be pulmonary arterial hypertension. So let's see, how does scleroderma affect the pulmonary circulation or affect pulmonary hypertension? It is from a kaleidoscope of pathogenesis. One of it is increase in pulmonary artery. Patient with scleroderma have accelerated atherosclerosis of the pulmonary artery, and this lead to pulmonary hypertension. And they also affect the lung, because patient with scleroderma has this lung involvement called pulmonary fibrosis, and also they have a lot of they throw a lot of blood clots because of hypercoagulability, and which lead to blood clot in the lung by virtue of chronic thromboembolic pulmonary hypertension. And also by age, when people age, and they have developed stiffness in the heart. So when they develop stiffness in the heart compliance decreases, develop diastolic intervention, and this contributes to the development of pulmonary hypertension. So why it is important in the sense that, to note that we divide pulmonary hypertension into these groups. Group 1, the pulmonary arterial hypertension that we are focused on today. Group 2, pulmonary hypertension from heart disease, and group 3 from chronic hypoxic lung disease. Group 4 from pulmonary hypertension from chronic blood clots, and group 5, this unclear mechanism from whatever underlying immunological disease. And scleroderma actually covers all these groups. So that makes it difficult, and makes it difficult for us to have a proper diagnosis, because only with a proper diagnosis we can properly treat the patient. So why it is important to have a proper diagnosis? So this slide shows why, because when you have scleroderma and you have pulmonary arterial hypertension, you could treat the patient with pulmonary arterial hypertension specific therapy, which is your Viagra, which is your Bosantan, which is your Rosiguet. So these are the PAH specific therapy, which I will dwell with in my further in my lecture, right? So if you have left heart disease, you have heart failure on top of that, scleroderma affecting the pulmonary hypertension, you should treat the patient, with water pills or Lasix to improve the symptoms. And if you have very bad hypertension, the possibility of adding antihypertensive would help in treating this patient. And if you have lung fibrosis contributing to the pulmonary hypertension, this is treated with oxygen therapy and possible lung transplant, and all the medication that has been talked about by Professor Faizal earlier, right? And if you have chronic thromboembolic pulmonary hypertension, we have a pulmonary arterial hypertension specific therapy, which is Rosiguet, which can be used to treat chronic thromboembolic hypertension. We have to put patient on anticoagulation, and surgical embolectomy, which offer cure in this cause of pulmonary arterial hypertension. So when we see patient in the clinic, patient again we present with a myriad of symptoms to you. So most of the patient that you see, they have scleroderma, and they report fatigue, and they report lightheadedness, and some of them report chest pain. However, most of them with pulmonary hypertension will come to you with a shortness of breath. And when this actually occurs, right, and so this is where you know that something sinister is going on. And when the patient reports to you that they have a swelling or edema, so you know that the disease is already advanced. This is really important because in average, upon noticing the symptoms to an accurate diagnosis of pulmonary hypertension and its etiology for treatment, it takes 2 years. And by that time, 75% of patient has progressed to functional class 3 or 5 at the time of diagnosis. So 3 or 4 is a bad functional class. So it transcends to a worse prognosis, as shown in this registry in the European team of pulmonary hypertension. You know that if you have a functional class of 3 to 4, you can see the trajectory of the graph. The trajectory of graph shows that you have poorer prognosis. Yeah, and does it help? When you screen patient earlier, when you diagnose patient earlier and put them therapy, does it help in the patient prognosis? The answer is that yes, because this is the PHAROS registry, a registry from the US, which shows that patient who has pulmonary arterial hypertension, right, which is diagnosed early as compared to patient who wasn't diagnosed with pulmonary hypertension early and put on specific pulmonary hypertension therapy to treat them, they recover. They have an overall better survival rate, as shown in the graph. So how do we screen patient? So patient has a bit of symptoms, right? And this patient has scleroderma, possibility that this patient would have pulmonary hypertension. First, you send for a chest X-ray. So chest X-ray is very simple. Everybody can ask for chest X-ray. Doctors, even almost everyone, even junior doctor can send for a chest X-ray. And you can see on the left side of the screen here, right? This is a normal chest X-ray. So this is a normal chest X-ray, normal heart. The heart is nice. It's not so big, and the pulmonary vasculature is okay. And as compared to the chest X-ray on the right side. So the chest X-ray on the right side, so that is the lingular area is straightened out. So there is a strain in the right ventricle. And also you can see there is a prominence in the pulmonary artery. So this prominence in pulmonary artery suggests that there is a strain in the RV wall. So you can say, oh, this has, and so, this patient probably have pulmonary hypertension. So being a cardiologist, and ECG are like, this is what I do every day, and this is among all other tests. I'm good at interpreting ECG. Hopefully, so you order an ECG, and ECG is a simple order to what ECG. So when you look at the ECG, like this patient here, you notice that this patient has a few criteria that suspect an RV strain. So number one is this ST depression with T inversion, which is shown in V3, yeah, and also this axis deviation, which seem to deviate more to the right side. And also, if you look at lead 2 there, look at lead 2 properly, yeah, you can see the P wave. The P wave is tall and pointed, not the normal round P wave, right? So this P wave is what we call P pulmonale, and it is suggestive of a right heart strain. Okay, so but having said that, I know that a lot of people, if you see this kind of ECG, you would always refer straight away to the cardiologist, right? Because this look like an ischemic ECG. So it can be difficult sometimes to interpret. So if this patient has chest pain with this kind of ECG, you always treat as ischemia first. If this patient doesn't have chest pain, is just one, then you start thinking of right-sided heart failure. Okay. So Prof Faizal has talked in detail regarding pulmonary function test. So pulmonary hypertension test is a subspecialty test, and it is I think mostly used not to diagnose pulmonary hypertension, but to diagnose underlying lung disease or the possibility of lung disease in contribution to the pulmonary hypertension. And 6-minute walking test is a test that we do to assess the exercise capacity. Bear in mind, patient with scleroderma, sometimes maybe they have a bit of joint pain, maybe they have a little bit of skin tightening, and this possibly could impair their walking test. So be careful when you ask for a 6-minute walking test in this kind of patients, because they might not be able to do it properly. Yeah, and you use a box in that to look at their how severe, how good is their performance with the 6-minute walking test. Okay. So how about biomarkers? So in the biomarker in particular, I'm talking about is pro-BNP. Yeah, pro-BNP, as we all know, is a marker of heart failure. So it could help us. It cannot tell you which one is which, but it could tell you heart failure. Okay, so this patient heart failure. Right. So sometimes when you look at patient who has pulmonary hypertension because of the strain on the right heart, so the heart starts to to produce a lot of this pro-BNP, and it is shown by the team in Jack in 2004, and we can see that from this graph that if you have a high BNP, it also reflect in a high pulmonary vascular resistance and a high pulmonary arterial pressure. So it's berkadaran terus lah. And if you have a bad 6-minute walking test, you have a high BNP level. So you can see this slide. So meaning that if you are unable to exercise well, and you will produce more BNP level rather than if you are good. If you are good with your exercise capacity, you will have a reduction of BNP level. So where available, CT scan, HRCT, and a BQ scan, where available, is useful to diagnose other causes of pulmonary hypertension. Right? In the CT scan, you can see like this CT scan, a dilated pulmonary tongue. So this dilated pulmonary tongue is suggestive of stress in the heart, and it could be associated with pulmonary arterial hypertension. Okay. And you can see from the CT scan also the dilated right heart, the epicalization of the right heart. So the right heart in this CT scan, as I shown in yellow, is shown is big, and the RA is big, and the apical segment of the heart is taking over the function of the left heart. So this is suggestive of pulmonary hypertension because of the bigger volume of the right heart as compared to the left heart. And of course, the CT scan could also tell you whether there is a lung scarring or pulmonary fibrosis as shown in the HRCT. Okay. So then you have suspected, so echocardiogram. So it is important for the crowd to note that echocardiogram is to screen only, and it's not a diagnostic tool, because I have a lot of referrals, and after reviewing the echocardiogram that they do in private, and some physician, they have the audacity to start patient on pulmonary arterial hypertension drug without properly diagnosing the patient or properly doing a right heart study, and then referring this patient to me for further follow-up. So it makes my job really difficult, because when I see an echocardiogram which is suggestive of pulmonary hypertension, I note that this patient has a probable pulmonary hypertension. So what does the European Society of Cardiology say with regards to pulmonary hypertension? So with regards to pulmonary hypertension, and when you do the echocardiogram, you will see the tricuspid regurgitation, or the peak tricuspid regurgitation velocity by its Doppler value. So if the Doppler value is low, right, so you have a low probability of pulmonary hypertension, so your patient are okay. However, if they are intermediate, right, and high, right? Intermediate, especially, you have to look at other things like, dilation of the right heart, the IVC volume, and hence, if those measurable value are abnormal, right, and so you have a high probability of pulmonary hypertension. This is where you refer to the cardiologist for an invasive test. So this is invasive test. What I mean is the right heart study. So right heart study, the problem of doing right heart study is not doing it, because right heart study, although it's invasive, and use the veins in the leg and in the arm and also in the neck, and we put a catheter inside the right heart to measure the pressures in the right heart chambers, and also we try to wedge it mana kita menyempitkan dia di pulmonary artery, and we got the pulmonary arterial wedge pressure for us to differentiate whether this is pulmonary hypertension or this is pulmonary arterial hypertension. So those that cardiologists or respiratories like to treat is those patients with pulmonary arterial hypertension, because we have this pulmonary arterial hypertension targeted therapy. So the problem is not doing the procedure. The procedure is safe, and I like doing it. However, the problem is to get the right equipment to do it, and also to interpret it. Yes, so interpretation is a bit tedious and difficult, and I'm in the process of learning interpretation with Dr. Muiz in Serdang, who is the expert in pulmonary hypertension in Malaysia. So how does it go? Or whatever investigation that we did, right? And how does it measures, and how do we put it into our algorithm of management, right? So with all this tests done, we would put this patient on this what we call risk assessment. So you put all, you have your clinical risk assessment, you have the functional class risk assessment, you have your BNP level, you have imaging, and your hemodynamic studies. So you put them into this risk group. So if the patient is deemed as low risk, and the risk of mortality is less than 5%. So if you have symptoms, you can straight away start treatment for this low risk patient. So this is really important, and because if you have the intermediate and high risk, your aim of management, what is your aim of management, is to improve prognosis, meaning that if you have patient on this red color, you want this patient to be, you start all the treatments, and you want this patient to be in the green, in the orange color. And if you are in the orange color, you want to treat your patient up to this yellow color. So it is the goal of treatment is to improve your prognosis, your symptoms, your exercise capacity, your biomarker parameters, and also your hemodynamic values. Okay, so this is actually, I was a bit distracted by the phone, but this is a slide as proposed by the team in the European Society of Cardiology in 2018. So let's talk about treatment, pharmacotreatment of pulmonary hypertension. So since the year 1995, 1996, 2000, and now 2019 and beyond, we have made a lot of progress in the treatment of pulmonary hypertension. Zaman dulu, maybe when I was in school, 1995 to 1995, yeah, you only have oxygen, diuretics, anticoagulation, and vasodilators, which is still used today in patient who has pulmonary hypertension in relation to heart disease, right? So as we progress, we have a lot of these pulmonary arterial hypertension specific medication. So in the year 2000, you are introduced to a lot of this medication, which is bosantan, treprostinil, iloprost, sildenafil, ambristatin, and tadalafil. Interestingly, since in the year 2000, all the studies involving these medications are looking at not hard endpoint. They look at the improvement of 6-minute walking test and symptom relief. Not until the year 2019, where there was a proper study looking at this 3-point maze by virtue of the ambition study. So the ambition study studied two medication at once. So previously we used to start medication one by one in a stepwise approach. Now the paradigm of treatment has changed. So now the paradigm of treatment is we want to start combination therapy, which is better than a single drug therapy. So pillars better than ladders. This concept is also currently used in the treatment, not only in treatment of pulmonary arterial hypertension, but also in heart failure. So upfront, so ambition study looked at this ambrisentan plus tadalafil, and patient has a better prognosis and a better 3-point maze when compared to tadalafil alone. Okay, yeah. So, but we are in anticipation of the Triton study, which not only involve 2 medication, but 3 medication, the combination of 3 separate medication for pulmonary arterial hypertension. So these are the medication for monotherapy that is available. You have the calcium channel blockers. So be careful about calcium channel blockers. I know a lot of people like to start calcium channel blocker because it's simple, but in pulmonary hypertension, and only a select few of patients with pulmonary hypertension would benefit from calcium channel blocker. These patients who benefit are patients who has a positive oxygen reactivity test during the right heart study. So you give an oxygen, or you give something to an oxygen provocation test, and you look at the improvement of the hemodynamic. So during the right heart study, you have a hemodynamic degree, you give them oxygen challenge and see improvement. And if there's improvement of this hemodynamic studies, and then only you could prescribe this calcium channel blocker. So you have to understand this concept really well, because if you gung-ho je bagi calcium channel blocker, it not only improves the symptom, but it can make the patient worse. Okay, so other that we have other medication that we are familiar is your endothelium receptor antagonist, ambrisentan, bosentan, and macitentan, which cost a lot of money. And your phosphorase type 5 inhibitors, which are sildenafil, tadalafil, and vardenafil. Right, I only have experience in using sildenafil, and in this group also it is included the guanine cyclide stimulator, which is osiguat, and you have this IV treatment, puff treatment, which is your prostanoid. So these prostanoid are really expensive medication, and the newer one, which I'm not so familiar with the IP receptor agonist, which is the selexipag. So when you treat patient also, be careful, because you don't add similar class. So don't add 2 phosphodiesterase 5 inhibitors. Don't add tadalafil and also Viagra together, because that will be, it would potentiate side effect rather than potentiate a good effect to the patient. And not all combination are equal. So the only studied combination is ambrisentan and tadalafil. I know a lot of us will see a lot of combination with bosentan and sildenafil. However, the study involving the combination of sildenafil and bosentan haven't yield a good positive outcome in its result. So be careful. Okay. So this is many of my my last slide. So treating pulmonary arterial hypertension, it's very difficult, and sometimes it's very frustrating. Like your battle with Thanos. Thanos is very powerful. It's very difficult to treat. It's very complex, and treating it can be frustrated. However, and with the initiative of Prof. Syarif and Persatuan Scleroderma Malaysia has made the burden easier for us to treat. So Prof. Syarif is the leader, and he like to say himself as the Captain America lah, Captain Prof. Syarif. So so you know, to have a good team, you know, like the Avengers to fight Thanos or to treat is a pivotal point to move forward to help us in treating pulmonary arterial hypertension.